Okay. Hello, everybody. I hope everything is well with you all. On behalf of Canadent Education Center and Confidentis in Toronto and Bonafarin Company in Tehran, in Iran, we want to say thank you to Dr. Karimi for accepting our invitation to join us. As everybody knows, the topic is maxillary sinus augmentation that is necessary for is maxillary sinus augmentation or sinus lift, as you know, that is necessary for sometimes for implant insertion in upper jaw. Hello, Dr. Karimi. How are you today?
Hello, Dr. Zamanian. Thank you very much.
Dr. Karimi, we are looking forward to your great lecture. Thank you.
Thank you, Dr. Zamanian. It's my pleasure to join to your program.
Thank you.
And I hope for your more success in the way.
Thank you.
And hello to my colleague. And it is my pleasure to be here to share some comments and information about the maxillary sinus augmentation. But at the first, I must appreciate our Canadent, Dr. Zamanian, and Confidentis, Dr. Adibrad, and also Bonafarin Peyvand to set this program. Okay, the topic is maxillary sinus augmentation. Is a generally wide item, and I try to tell some note briefly. And okay, we start from the anatomic consideration. For a good understanding of the sinus augmentation, we must know about the anatomy of the maxillary sinus. Two important factors are here. The first one, bony walls, that we must know about the sinus. It's a pyramidal architecture. It has 6 walls that you know from the different section here, and in the coronal section you see the posterior wall, you see the superior wall, inferior wall above the teeth, and the lateral wall. And in the transverse section we can also hear the lateral wall. The lateral wall is important because the window preparation for sinus lift is done here, and the anterior wall, inferior wall, medial wall, and the posterior wall. And you can see here from the sagittal section that the superior, the sinus floor inferior wall, and the medial wall. And you can see the ostium here. The ostium is one of the compartments of the osteomeatal complex. This is very important for sinus graft, and we must have notice about it. What's the osteomeatal complex? In the upper part of the maxillary sinus, it is the ostium, which the duct for drainage of the mucociliary secretion of the sinus and also foreign body, and this leads to infundibulum, and also in the lower part uncinate process and ethmoidal process, and after that, the direction is toward the superior and medial, and after that, the secretion will go to the middle meatus and then to the nose. This is a pathway of the drainage of the maxillary sinus. And the CT scan, you see the ostium very well, the infundibulum, the direction of it, and after that, to the in medial meatus. You can see in the next picture that if the ostium, to any reason, occluded or obstructed, for example, for deflected uncinate process or deviated septum or polyps in the sinus, the pathway of the passage of the secretion will occlude it, and if the patient has some non-patency of this osteomyelitis complex, there is a more chance for infection in sinus. There is a CT scan from the ostium that it's not patent, and you can see the inflammation entire the sinus, maxillary sinus. We must have attention that in CBCT scan that usually we order to radiologists, we can see, based on the paper, we can see the area up to 35 millimeters above the patient's occlusal plane. So if our patient has a history of sinusitis, chronic sinusitis, or other pathologic condition in the sinus, in the most cases, we cannot see the patency of OMC or ostium in CBCT scan. And if the patient has such history, we must ask from our radiologist to confirm the patency of the OMC. And if the CBCT scan cannot show, then we must refer to or order the maxillary sinus CT scan especially. How about the surgical note from this anatomic situation? Patency of OMC is very important in initial evaluation of our patient for prevention of complication. The research and showed that most of the complication after open sinus graft originate from the occluded or semi-occluded ostium. So we must have special attention to it based on the patient history. Second item, the medial wall. During the open sinus surgery, we must lift the membrane, Schneiderian membrane, to up, and we must expose the medial wall because we need this blood supply from the medial wall, especially when we use allograft or xenograft or alloplastic. We need more blood supply. But during the lifting or exposing the medial wall, we must take care, and we must do it very gently because the medial wall is thinner than the lateral wall, and if we push more pressure on this area, it can lead to bleeding from the nose and epistaxis. So, based on the papers, we must, before sinus lifting, CT image are recommended to detect anatomical variate, especially about osteomyelitis complex. And our recommendation that please note to this anatomic situation. How about the blood supply of the sinus? The sinus arteries originate from the maxillary artery, posterior superior alveolar artery, and infraorbital artery, and they supply and provide the blood to the sinus. And they have two anastomosis together, one extraosseous and one intraosseous. We have two anastomosis. Extraosseous anastomosis in 44% is seen, and it is about 15 to 20 millimeter from the crest, and it is close to the periosteum. And the intraosseous anastomosis, when it is lost, it around 5 to 10 millimeter from the crest, and in 82% it's in between canine and first premolar. And the important note that the diameter of the artery, if the artery is less than 1 millimeter diameter, it cannot cause a big problem during the surgery. But if the diameter is more than 1 millimeter, it's shown that it can cause severe bleeding. You can see the internal anastomosis in the bone and in the CT scan. So we must have attention during the CBCT evaluation that if there is any intraosseous anastomosis or not. How about the surgical note about the anastomosis? Considering the extraosseous anastomosis, we must note that during the vertical incision, because we like to have a good vision to the lateral wall for window preparing, and we must have a releasing incision. The releasing incision is mostly done in the mesial part between the canine and premolar. So if we pass from the mucogingival junction, it's better to not much extend. And after the passing the mucogingival junction, it's better to push this area with a blunt scissor or a blunt instrument to have a more access to area. Or if the end of the surgery, if we need to periostal releasing for tension-free closure, also we must calculate the position of the extraosseous anastomosis during the periostal releasing. Because in this situation, we can cut the artery and also severe bleeding. But generally, the bleeding from the extraosseous anastomosis is easily controlled with the pressure on it. But the problem is when we encountered with the intraosseous anastomosis during the window preparation. If we can detect the intraosseous anastomosis, we can modify the location of our window to prevent of damaging the intraosseous anastomosis, because the control of the bleeding from intraosseous is very difficult. And if the surgeon does not have enough experience due to severe bleeding and less vision of the area, it can be very harmful for the surgeon. If we in the literature, it has shown that in 20% of the cases, the surgeon may be encountered with the intraosseous anastomosis and damage to it and severe bleeding. So if it happened, what we can do? The first is changing the position of the patient's head to upright. because when the patient in the supine, the blood is go more and the bleeding continue. So the first is the changing the patient head and the gas pressure, but gas pressure is not enough because the bleeding is from inside the bone. So we must apply an instrument over the entrance of artery if we can, because we must need to have a good vision. And if we can reduce the bleeding, we must continue to lift the membrane. Absolutely, we cannot stop the surgery. We must continue to detach and to lift the membrane. And if we are sure about the lifting the membrane, the better and the best choice is crushing the bone with an hemostat, with an rangure, because with the crushing, the artery inside the bone push and compact. Also, electrosurgery and high speed is recommended, but both of them can lead to membrane perforation. How about the membrane of the sinus? The maxillary sinus mucosa or Schneiderian membrane is a bluish red. After the removing the bone, we can see this picture, this view of the membrane as a normal membrane. It's a pseudo-stratified ciliated columnar epithelium. It has some glandular and goblet cells during it. So this ciliary movement continually exists to have a secretion and movement toward the ostium. So mucociliary clearance is done for the cleaning the sinus from foreign body and from the inflammatory secretion due to pollution and other factors. There is an important role of the oxygen here, because these cells mostly needs to high oxygen level, and the blood supply of the sinus cannot supply it. So the passage of air in this the internal space of the sinus can provide the oxygen for these cells. So if there is any obstruction on the ostium here, the passage of the air reduced, and also the oxygen cannot reach to the cells, and the sinus will be susceptible to infection. You can see the flow and the direction of the movement of the ciliary to drain the secretion to the nose. What's a surgical note about the mucociliary? During the open sinus lift, I will tell you about the window, the location of the window preparation. But if we have a window in the distal portion, maybe we can produce or form an isthmus here. For example, in this area, I cannot completely fill the anterior part of the sinus, or in this area that I mark, you can the isthmus. During the secretion and ciliary movement to the ostium, this isthmus has stasis of the movement, and maybe this area can leads to more susceptibility of the sinus to infection. So it's better our bone graft usually touch to the anterior wall of the sinus, so the mucociliary function can be done easily. How about the anatomic variation? There is some variation in the sinus which we must consider them. The first one is a septum. The septum may be complete or incomplete. In the sinus, they may originate from the lateral wall, from the medial wall, and in 33% of the dentate percent, it has shown, and 22% of edentulous. And it demonstrates that the parafunction and occlusal forces, based on the Carl Misch concept, this is the process of adaptation of the bone to occlusal forces. So if the patient has their teeth, so the septum can form because or due to the occlusal forces. There is a complete septum which divided the sinus into two parts, and here you can see another septum. How we can manage them? If we detect the septum in the CT scan, maybe in some cuts of CBCT scan we cannot see the septum, and during the surgery we see it. But if we can detect before the surgery, if the septum is in the medial median of the sinus from the anteroposterior, so we can prepare two windows. The existence of the septum increase the chance of perforation of the membrane. And if the septum is in the mesially or in distally, it's very difficult because we must start the membrane lifting at the one side and touch the medial wall, and also turn and start above the septum. And this area is very sensitive for perforation of the membrane. Sometimes the septum are useful for us when we want to have a closed sinus lift and we see the septum, then we can use of this bone architecture for more stability of bone, in sometimes without biomaterial, or in this case I did it with the biomaterial, and we use from the septum. Another variation of the sinus graft is the angle between the lateral wall and the medial wall. If this angulation has less, the approach of the sinus lift will be more difficult and the chance for perforation increase. And if this angulation increase and between the lateral and medial wall, the sinus lift will be easily can be done. So we must, during the evaluation of the CBCT scan, we must check it. The less angulation more seen in atrophic ridge, so the process or the procedure will be more difficult, and we must have attention to it. How about the pathologic condition? There is some pathologic condition. The first one is inflammatory disease, which originates from the teeth, odontogenic rhinosinusitis. Sometimes the roots of the premolar and the molar are inside the roots, inside the sinus, and if there is an infection, they can lead to sinusitis. In this situation, the involved teeth must be treated by root canal therapy or extraction. If we have a plan to extract, then after 6 weeks we can go to the sinus graft. Another pathologic condition that is very common is mild mucosal thickening. The mild mucosal thickening we can see is in the most of the CBCTs due to a lot of factors, pollution, allergy, and other factors. that is, it doesn't need any treatment, and we can go to the sinus graft. The mild mucosal thickening is very detect very easily in the CBCT scan, but acute rhinosinusitis, chronic rhinosinusitis, allergic rhinosinusitis, they have not any specific view in the CBCT scan, and we must have a good history of the patient to diagnose. In this situation, in all of them, we must refer the patient to ENT specialist, and after their treatment, if they confirm the OMC patency, then we can go to sinus graft. But as I will tell you about the prophylaxis, most of them need to more antibiotic coverage, and especially in chronic sinusitis, they need to more antibiotic and antifungal coverage, because in chronic sinusitis it has been shown that there is some fungal infection in chronic sinusitis. And in allergic sinusitis, the ENT treatment confirming OMC, and we must choose the best time for surgery. If the patient has seasonal allergy, we must choose the best time based on the less allergic. You can see the mild mucosal thickening. Another pathologic condition of the sinus is cystic lesion. At the first and more common is pseudocyst. It's a mucous retention cyst. It's only the accumulation of the fluid under the membrane. It has not epithelial lining, but it's surrounded by the fibrous layer. It is asymptomatic. It has been shown in 30% of the cases. How about to manage it? Because it's common, and we can see it more in CBCT scan. Our management is based on its size. If the size of the pseudocyst is less than 10 millimeter, there is not any treatment. We can go to the open sinus lift, and the fluid will drainage during the surgery. But if it is more than 10 millimeter, after the sinus lifting, this size maybe occlude this ostium. So it's better to refer such situation in big pseudocyst to refer to ENT specialist to drainage it by endoscopic or other procedure, and after that we must go to do it. But retention cyst is more smaller, and rarely we can define them in CBCT scan, so there is not any treatment before the sinus graft. And we have another pathologic situation under the name of primary maxillary sinus mucocele. It occupies the whole of the sinus space, and it's more radio opaque. And this situation, absolutely, we must refer the patient because it obstructed the ostium. And after the treatment, we can go to open sinus lift. Okay, after such initial evaluation of the sinus graft and surgical notes in relation with them, we have two main options about the closed, about the sinus augmentation. The first one is closed or crestal sinus lift, which we can do with the osteotomy technique, which originally introduced by Tatum, and it's completed with Summers. Nowadays we know this technique as a Summers technique, the balloon technique or hydrolift technique. And the open sinus lift, which is we must discuss more about it. It can be done at one stage with immediate implant placement or two stage delayed implant placement. Which factors are effective to choosing one of these approach? The first one and the more important one is available bone. We must calculate how much bone is and we have under the sinus floor between the crest and the sinus, and based on this amounts, we can decide to go to close open sinus lift or crestal approach or to a lateral approach. We must do this calculation based on CBCT scan because the OPG is not definitely can show the exact amounts. So based on the literature and the books, if we have between 5 to 6 millimeter bone under the sinus, we can go to closed sinus lift. But less than this amount, we must go to open sinus lift. It's a general rule, but we can modify that I will tell you. And if we have around 3 millimeter, at least we can go to one stage immediate implantation with sinus graft. But if we have less than 3 millimeter, 2 or 2, due to getting primary stability of implant, it's not recommended. But some of expertise surgeon do it with a less amount of the bone, but generally the general recommendation is that less than 3 millimeter is better to do two stage. One stage for maxillary sinus augmentation, and after 4 to 6 months, we must go to implant installation. The width of the crest is important, and in the cases that the surgeon do the one stage with little than the 3 millimeter bone, mostly the width of the crest was good with the good width. The another factor we must consider the sinusoidal angulation. If we are going to do closed sinus lift, in this situation, the chances of the perforation of the membrane will increase, if it's possible, but due to different depths of the area during the drilling, the chances for perforation will increase. The number of implants. If we like to have a closed sinus lift for single tooth or 2 or 3 tooth is different. When we like to have a closed sinus lift for 2 teeth, it's more easy. So if we have 5 millimeter bone for 2 or 3 teeth or 2 or 3 implant, we can do it more easily. That if we have 5 millimeter under the sinus for one single implant, that the chance for perforation will increase. Another factor that we must consider is the age. For elderly patient, we can consider the shorter implant, and if we have, for example, 5 millimeter or less, 4 millimeter, we can go to closed sinus lift and put the 8 millimeter implant. Or in the gender, regarding the gender, in the females, during the less mastication power, we can consider the shorter implant as, or in patient they have poor function, we must consider the longer implant. And also we must consider opposite arch situation that will be effective in our decision. Regarding the age, if we like to put one single implant for a young person, for example, for first molar, and if we have 5 or 6 millimeter bone under the sinus, we prefer to do open sinus surgery and put at least 12 millimeter implant, because the young person needs to use this implant for a long time. About the accessory factor also is about the patient expectations and also economic condition. For example, in some elderly patient, they scare from the sinus lift, and we can put the implant in anterior and posterior wall of the implant with more angulation and correct it with the prosthesis. Closed sinus lift can be done without material if we like to lift the membrane 2 millimeter. We don't need to put any material, but if we like to have more lifting, then we must push some particle of bone, any bone that we will tell about them to you, and push and lift the membrane with the biomaterial. Also, we can do the closed sinus lift immediately or fresh socket implantation, in case you can see after the extraction of the first and second premolar. We can do this installation of the implant. I did it around 10 years ago, and you can see the very stable situation and there's a very good situation in the sinus. Before starting the surgery, we must ask our patient about the smoking, because the smoking interferes with ciliary function, reduction the responses, immunologic response, increasing IgE responses, and reduction of local blood flow. So if the patient want to have a sinus graft, then they must stop 15 days before surgery and extend 4 to 6 weeks after the surgery. And we have an absolute contraindication of the sinus graft for the heavy smoker that use more than 1.5 pack per day. We must do prophylactic medication for open sinus graft for all of patients, because the sinus is susceptible to infection. And in the patient with history of sinusitis or without history of sinusitis, we must have a coverage of antibiotic before surgery. The choice of the antibiotic is augmentin or coamoxiclav, they are the same with different dose. BID or TRID based on the patient history. If the patient doesn't have any history, BID is enough, or if the patient has the history of sinusitis, TRID. And the other antibiotic is Septum or doxycycline, 100 milligram. The patient must take the antibiotic 1 day before surgery start, and is continued 5 days after. Some of the surgeons prefer to have a local antimicrobial medication, for example, cefazolin or clindamycin, both of them injectable. And for example, cefazolin 1 milligram, it must mix with the biomaterial during the filling the sinus, or clindamycin, or metronidazole based on the chocron. The metronidazole solution is only in the hospital, but it can mix with the biomaterial to fill in the sinus. The other prophylactic medication is glucocorticoid. We can give the patient dexamethasone 4 milligram, and they start from the 1 day before the surgery, 2 tablets at the morning, 2 tablets at the night, and 1 tablet at the surgery morning and 1 after that. Or we can use the dexamethasone injection, 1 before and 1 after the surgery. Also, we can use the decongestant, phenylephrine, for the reduction of the inflammation, but it's because they have a rebound effect. It's maximum, you can use maximum 3 or 4 days before and after surgery. For the starting the surgery, we need to deep infiltration, and it's enough in the most common cases. It's better to use medium action or long action anesthetic and take or give it time, enough time to establish a vasoconstriction effect of the or anesthetic injection. And rarely we need to V2 block. In the case we have a CBCT scan, and our plan is to have an open sinus here, and all about the design of the flap. The flap must be crystal, slightly too palatal, and then we have a releasing incision. As I told you, the incision must pass from the mucoceal junction, but not much to cut the extraosseous anastomosis. And if we like to have any location that we want to do the vertical incision, we should not involve the puppy, and we must do it in the line, in the marginal line beside the papilla, and to preserve the papilla, not the middle of the papilla, or not the middle buccal, only beside the papilla. And the mucoperiostal flap elevated, we must have a good vision in this area, and when we reflected the flap, the sinus will show itself, because due to different translucency in comparing with the neighboring bone. When the bone is removed, we have 2 techniques for window preparation. The first is wall off or Bowser technique, that we start from the middle and we extend around it, and we remove the totally bone. And the second one is trapdoor. In the trapdoor, we use the round diamond burr or piezosurgery tips, and we outline the window, and this area will remain. We can wick it, but not completely remove the bone, and then we, with the pressure, it at the trapdoor return inside the sinus, and it will put under the membrane. The success rate is the same, but for the trapdoor, we need to prepare a big window, and if we like to have a small window, the remaining bone is not enough to be effective. And for the wall-off, there is a special conical burst. A lot of companies introduce it. The important note is, where is the best place for window? There is two note that we must prepare the window as mesially as possible for better vision, because due to our position in relation to the head of the patient, usually in the left area, our vision tends for us to prepare the window distally. So it's better to check it in the mirror, and if we prepare the window as mesial as possible, we have better vision. And if we have better vision, we can prevent of the membrane perforation. A lot of perforation is done in during the mesial lifting. And also, as I told you, prevention of isthmus formation that prevent of the mucociliary drainage. And about the apicocoronal position, as I told you, it's better when we detect the mesial wall of the sinus. It's better to prepare it as mesially as possible. And if we consider the crest and the roof of the floor of the sinus, the inferior border of the window must be around 2 or maximum 3 millimeter above the sinus floor. If we prepare the window superiorly, then we must come back through the sinus for lifting from here, and it will increase the chance of perforation. So it's the location of the window in relation to sinus floor and the anteroposterior position. What's the best area for starting the membrane detachment and lifting? The upper part of the window is the best place. We must start sinus lifting from here, because most of the perforation are done in the initial stage of the sinus lifting. So if we have any perforation in here, because at the initial step we don't know about the behavior of the membrane carefully. So if we have perforation in this area, the management of the perforation in this area in comparing with this area is very, very easy, because if we have perforation in this area, we can extend from this area, and when we detach the membrane from the inferior border, then this perforation will fold it on it, the membrane will fold it on it, and the perforation will close automatically. The second area is the mesial or distal portion, and the fourth is the inferior, that we, in all of them, with different curettes, we must be in touch with the bone, and we should not move without touching the bone. And you can see the different curettes with different angles. After the elevation, we must touch the medial wall, because we need to more blood supply, and then we can go to the filling the sinus. After the elevation, the membrane, when the patient breathes, the membrane come down and up and down. Movement of the membrane is a good sign that we can lift the membrane without any perforation, but it is not absolutely, we cannot depend on it absolutely, and but it is a good sign. We can fill the membrane with different biomaterial and cover it with a collagen membrane, and after that they close this area. If we like to put the implant simultaneously, then we must fill the sinus in the medial wall, mesial wall, and inferior. Because if we put the implant, after that, we cannot access in the posterior of the implant, and maybe we remain the hollow spaces. When we put the biomaterial in the sinus, which direction is recommended? The direction toward inferior, that we can put and push the membrane inferiorly, which leads to lift the membrane, and also to mesial. Due to position of the patient's head, most of the biomaterial tends to go to distal, and so we must pack the biomaterial toward the mesial, and if we can do it, we can prevent of isthmus perforation, as I told you before, I showed you before. Is a case after the sinus lifting, and if we like to put the implants at the same time after the elevation of the membrane, we must prepare the implant socket, and after the preparation the implant socket, we must fill the sinus. We can fill with the prefab biomaterial, which the disposable syringe, or with the bone applicator, and after that filling the sinus, then we install the implant and closure the area. For two-stage surgery, we must, if we have a very small bone in this area, we must fill the sinus before that, and after 4 or 6 months, we can put the implant at the area. This is the case before, and after that the surgery, you can see the but during the filling the sinus with particles, we must have enough pressure, not much, to penetrate or push the biomaterial to sinus, or really little pressure that remain hollow spaces. How about the healing of the biomaterial? I must tell you that touching the medial wall is necessary and is the main goal, because if we remain the membrane here and push the and fill the sinus, we lost one of our blood supply here, and maybe this, the formation of bone will decrease. So it's better to lift completely, and the healing and blood supply started from the surrounding, and this area, the center of the graft, is the lastest portion that will revascularize. I think due to my time, I must pass from the biomaterial fastly. We have 4 category of graft: photogenic, allogenic graft, xenograft, and alloplastic, based on the bioactivity and biomechanical stability. Autograft is a gold standard for all of the procedure in oral implantology, but in sinus graft, I must tell you that it is not gold standard, and nowadays we use a lot of graft alone or in combination on mixation with autogenous bone graft, and the single autogenous bone graft was significantly more resorbed than the autogenous bone combined with the bio-os graft or other graft that they have less resorbability and they have biomechanical stability. The allograft also have less success in the sinus graft, and there is a lot of doubts about their osteoinductivity, and today most of the papers believe that they are osteoconductive. And xenograft, they have a very successful, they were and they are very successful in sinus graft, and also alloplastic. Between the alloplastic graft, the biphasic calcium phosphate graft, which use the beta biphasic calcium phosphate ceramic, which they have different percentage of the hydroxyapatite and beta-3 calcium phosphate, and they use from two advantages of these biomaterial: stability and resorbability, because the better bioactivity from beta-3 calcium phosphate and better biomechanical properties from the HA can lead to more success and decreasing the bone height inside the sinus. Again, you see the importance of the exposing the medial wall. It's a case, and for sinus graft, after the filling, it is done around 13 years ago, and it's very without any decreasing the height of the bone, because we use such less resorbable material without autograft. And this is the follow-up, and this is another case, and that which we done. If the membrane lift safely to up, we will have this situation, it's round area, and there's not any penetration of the biomaterial inside the sinus. This is a case, another case, and this is a case. How about the post-operative instruction? We must tell to the patient, beside the general instruction like putting the ice pack and eating the cold food or liquid food, but some special note about the sinus graft: they must prevent of sneezing from the nose. They must they should not go to pool, or especially if the patient is under the water due to changing the pressure, or exercise and up and down moving the head, and also these are the instruction that the patient must notice after the surgery. If I have time, I tell you about in few minutes about the complications.
Yes, you have, doctor. Please.
Yes. Thank you, doctor. Thank you. The complications in the sinus graft divided in two groups. One, intraoperative, which consists of membrane perforation and septum difficulties that maybe leads to perforation and bleeding. And the post-operative perforation is about the short term and long term. About the membrane perforation, if we have small perforation the best way is to continue carefully to lift the membrane, and if we can lift the membrane in from the another side, the membrane will folded on it, and the small perforation means 5 or less, 5 millimeter or less. But if the perforation is with this small perforation, after the lifting, we need to put a collagen membrane or collagen plug under the membrane, or our PRF. And if the perforation is more than 5 millimeter, if we can lift the membrane in another part very well, then we can put a collagen membrane, but the collagen membrane must be fixed over the bone, not inside the sinus, but outside the sinus must be with a tag or with a screw. We must tighten it, because for prevention of the moving the membrane inside the sinus. And if we have the large perforation, the best way is to stop the surgery and closing the area, and also postponing the surgery to at least 3 or 4 months after that. I hope that this comments is useful for your dear colleagues, and thank you for Dr. Zamanian.
Thank you, Dr. Karimi, for your interesting and informative lecture and wonderful presentation. It was very nice. Thank you so much.
Thank you. It's my pleasure.
We hope see you soon, and of course tomorrow we have Instagram live
yes,
with Dr. Karimi and Dr. Barshosaz and Dr. Jafari as well about this lecture. Thank you, everybody. We will see you in our webinar in the next Saturday. Thank you so much. Thank you, Dr. Karimi, again.
Thank you very much. Thank you.
Bye.
Bye.
Bye.